Warm welcome to this beautiful evening.
We can't hear you, doctor. The mic is not working.
I'm recently joined to this RxDx hospital. I'm basically assistant professor in Media Medical College. I'm just going to talk about the approach of asthma. Dr. Shivaraj has told me to just talk about that asthma. I think especially this Whitefield, Brookfield and Martali, because of too much of pollution and all these things, we are seeing so many patients of asthma patients, especially allergic bronchitis and asthma patients. So many patients, like especially the practitioner, general practitioner, you can see every day, like the patient's main complaints will they'll come. Sir, when I was there in my native place, I was absolutely okay, sir. When I came to Bangalore, that is especially Martali, this thing, I started with all sorts of symptoms and all these things. So just we wanted to know, like, what is this asthma, how to deal with this asthma, how to approach a patient with asthma. Before going to the approach to the asthma, I just wanted to tell about the definition of asthma. There is a GINA. GINA is a global initiative for the management of asthma. So this GINA has made a definition. It is a chronic inflammatory disorder of airways in which many cells and cellular elements play a role. This chronic inflammation is associated with the airway hyperresponsiveness. This leads to the recurrent episodes of wheezing, breathlessness, chest tightness, coughing that particularly more in the night and early morning. And these episodes are associated with a widespread airflow obstruction. There is airflow obstruction. This often, sometimes without treatment also they can completely reversible. Sometimes with the treatment it can able to reversible. This is the definition of asthma. I'll just explain all the sentence by sentence in my subsequent slides. Coming to how to approach an asthma patient, especially in the children's. This was the guidelines from the BTS, British Thoracic Society guidelines. The asthma, especially in the children's, they are mainly divided into the high probability of asthma. High probability. That means based on the criteria, there are some criteria they are defined. Based on the criteria, if the children, if the kids is fulfill that criteria, you can label definitely as asthma. Low probability, there are also some criteria, and intermediate probability, the diagnosis may or may not be. What are the criteria for high probability? What are the clinical features for high probability of asthma? Usually they are defined like there should be more than one of the symptoms. The symptoms usually wheeze. As you all know, like what is the wheeze? Wheeze is a musical sound. And sometimes the patient will come like some sort of whistling sound is coming from my throat. So that is a wheeze. And cough. As you all know, like what is a cough? And also difficulty in breathing. That is shortness of breath. So they cannot able to take a complete breath. There will be shortness of breath. So they feel like I can't able to take a complete breath. And also chest tightness. Along with they may sometimes complain of difficulty in breathing and dyspnea. So if you walk certain distance, suddenly they will become breathless. And also if you can't able to do any minimal work or householding work also. And the children especially, they cannot able to play. If they play, they start breathing difficulty. And usually the symptoms are so frequent and recurrent. And usually these symptoms are more common in the early morning as well as the night. Why this is more common in the early morning and night? Usually there is a decrease in the cortisol levels in the body in the early morning as well as in the night. That's why there is an increase in the symptoms, especially this for the atopic patients. There will be more symptoms in the early morning as well as the late night. And usually the responses, there is an immediate response of exposure to any pollens or any birds or any dusty environment or any cold air. And this occurs apart from the course. What is that meaning? Occurs apart from the course. As you all like, I think some pediatricians also I think. So usually that kids, they will get a cold so frequently, maybe in a month once or twice. Once they get the cold, it can goes to their cough and all these things. Usually the kids' airways are very smaller airways. When the airways, then they got inflamed the airways, they will become a narrow. When they are narrowed, they may start with the wheezing symptoms and difficulty in breathing, all sorts of symptoms. So if the kid came with a cold and is landed up into this type of wheezing and all these things, you cannot label the baby and the kid as a bronchial asthma. You have to observe this type of symptoms other than the cold. So that means they occur apart from the colds. And there should be a personal or the family history of atopic disorders. As you know, like atopic disorders is a familial disorders where the person is overreacting. That is hyper-responsiveness to the normal antigens. A normal person, when he has been exposed to the normal dusty environment, his body may not react so drastically. like the persons who are having atopy. Atopic means like is the familial history, the family history of atopic disorder. If it is there, definitely with along with the above symptoms, you can definitely think like there may be a bronchial asthma. On examination, there may be a bronchi. Bronchi are your. We have heard like bronchi is a continuous musical sounds. And history of improvement. If you give a, for example, trial of drugs, if you wanted to give on the baby after suspicion of bronchial asthma, definitely they will come after 1.5 months or 2 months with a good response to the treatment. So then definitely you can label there may be a bronchial asthma. This kid having the bronchial asthma. So if that was a bronchial asthma, what are the criteria for the low probability of bronchial asthma? Usually this is the symptoms what I already explained in my previous slides. The symptoms with the cold only with no interval symptoms. That means the baby will be sick only during the cold. When he's got the cold only he'll be sick. That means once he got the cold, he will develop into the cough, that breathing difficulty, all sorts of the symptoms. When the baby is free from the cold, he may not be having any respiratory symptoms. Like only baby is having the isolated cough in the absence of the wheeze or in the absence of the difficulty breathing. Just based on the cough, you cannot label the baby as a bronchial patient. And history of the moist cough. What is the meaning of moist cough? As you all know, bronchial asthma is an airway disease. Usually airway disease, the secretion will be very minimal. So if there is a moist cough, moist means there is a expectoration will be there. When there is a expectoration is there, definitely there may be a parenchymal involvement is there rather than the airway disease. If the baby is having the moist cough without any wheezing or without any breathing difficulty, definitely there may be some definitely parenchymal involvement is there rather than just an airway disease. And repeatedly normal physical examination are judged when the symptom. Even if the baby is having continuously cough and all these things, if you auscultate the baby, there may not be any symptoms of the bronchi and all sorts of symptoms. And if you wanted to do or if you wanted to confirm with the normal peak expiratory flow, I'll just explain the detail in my subsequent slides. What is the PF, what is the spirometry. Even if you wanted to do during the symptomatic consult, it absolutely appears to be normal. And if you wanted to try, but because like you can't get the proper history, if you wanted to try with the asthma treatment, the baby may not respond. The response may not be adequate as you see in the high probability of asthma. And after seeing all these things, you have to think of something else rather than the bronchial asthma. This is a very difficult entity. Most of the people, most of us will see this type, intermediate probability. So neither there nor here, neither there nor here. Like because you cannot able to get a proper history one thing, and they may not be knowing what is that wheezing and what is that breathing difficulty. Especially getting the history in a case is very tough job. So that time what you have to do, like you have to watch. You have to watch, especially when the kid is free from the cold, whether he is having any respiratory symptoms or not. That's especially you have to watch for at least some couple of months. And if at all, if you wanted to given bronchodilators, especially inhaled corticosteroid should be given. So if you give and you have to observe for at least 1 or 2 months. If there is symptoms or improvement is there, definitely you can think like there may be a bronchial asthma possibility. So here definitely you have to go ahead with some of the investigations. What investigations? If the kid is more than 5 years, definitely you have to see for the airway obstruction. The test is the spirometry. Especially kids between 2 to 5 years, there are some more tests they have mentioned, like this is specific airway resistance and impulse oscillometry, and there is an increase in the residual values. As you know, like this is an obstructive airway disease. When there is obstruction is there is a air trapping will be happening in the lungs. When there is air trapping is happening in the lungs volumes will be increased, the residual volume will be increasing, therefore there is a function residual capacity will be increasing, the total lung capacity also will be increasing. But all this tests, especially between the 2 to 5 years age, it is not actually in a practical purpose, not in a hospital, but only they are still in the research. They may come definitely in future. What are the other investigations? Still if you wanted, as I told you in the definition only, it is a hyper-responsiveness to the airways. So there is, out of the hyper, just that hyper-responsiveness, this is called metacolin challenge test and exercise challenge test. To see for you know like that eosinophils are the cells which are predominantly present in a case of asthma. The test for the eosinophilic airway inflammation are one is you have to induce the sputum that eosinophil differential eosinophil count, and another is exhaled nitric oxide concentration. I'm just going to tell in detail in my subsequent slides. Yeah, So if you wanted to check for the atopy, as I told you, atopy. So this is the positive skin prick. Here, like what they are doing, like positive skin prick test for the particular, for example, certain antigens, especially the dust mite is the most commonest culprit to cause the patient to become sick. So dust mites everywhere it is there. So they put and they will inject an dust mite antigen along with the cockroach also. They can try for that skin prick test and Parthenium, all sorts of minimal that antigen they will try. If the patient is, if the baby is atopic or there is a positive skin test, you can definitely label as an atopy. Rather, you can label as a bronchial asthma. And if there is this, for example, raised specific IgE to cat, dog, if the patients in the home they are having any pets, if you wanted to check for there is a raised specific IgE for this, there also will be raised. Chest X-ray does not definitely tells what is the how it definitely does not give any that much of clue. But if you wanted to rule out some anything else other than the bronchial asthma, definitely it is a very good tool to see for the other causes. Yeah. If the patient is high probability asthma, so better not to dig too much of detail further investigations and all these things. Just to start a trial of treatment. So you are not giving any oral medication, just give some inhaled corticosteroids. Inhaled corticosteroids are the drugs for the treatment of asthma. Just give a trial of drugs for at least some 1 to 2 months and see the response. If there is a response is there, definitely you have to continue. If it is really needed, you can go ahead with the treatment. And you have to review and assess the patients. How is the pain and all this. If you wanted like that, further testing should be reserved for only if there is a poor response. If there is a low probability of asthma, so
sir, is it not routine to combine with the long-acting beta agonist? So only
I'll tell the steps how you have to start the treatment of the steps. I am going to tell all. Okay. And especially in a low probability of asthma, so that you are thinking of other than the asthma, so you have to go for the further investigations, or if it is not possible, you have to refer the specialist to go for the further investigation. To summarize my approach in a case, so based on the clinical assessment is very important. As for the history, as for the family history, and as for the symptoms. If you are thinking of high probability of asthma, just give a trial of asthma treatment, especially inhaled corticosteroids are the first line of drugs. Along with you can add the LABA, long-acting beta 2 agonist, or inhaled corticosteroids. If you are thinking of just a mild asthma, just go ahead with the ICS rather than combining with the LABA. So if there is a good response is there, definitely you have to continue the treatment and you have to monitor the patient. If there is no response, but clinically you are strongly suspicion of there is a bronchial asthma, you assess the compliance, because most of the persons, like especially inhaler technique is very poor, very poor. They are telling like almost 80% of the technique is very poor. When the technique is not very good, there is no, not to think of how the inhalers will work and how it is effective. The compliance of the technique should be good, and whether they are taking the proper medications or not also you have to check. If it is not there, then you have to correct and you have to observe and you have to monitor. If it is a low probability of the asthma, then you have to investigate further. If you got any cause, then you have to see further, you have to treat for the cause. If there is a response, then you have to go ahead with the treatment. If no response, you have to further investigate. Here is the intermediate probability. Intermediate probability, here you have to go for the test. That is, one is lung function test, that's I told you, that is spirometry or PF, and the test for the atopy, that is positive skin prick test, or the specific IgE for the dogs, cats, and if it is positive, treat as an asthma. If it is negative, then you have to think for further cause for the symptoms. Likewise, there is an approach in the adults. So it is entirely different from the kids. Here definitely it's very easy to establish it. It's very easy to get the information from the adults, because they definitely tell what are the symptoms. Here they are given the guidelines like if there should be more than one of the following symptoms. Patient should be having the wheeze, either wheeze, or he is having the breathlessness or shortness of the breath, or chest tightness. Chest tightness means he cannot able to take a proper breath. His breath will be shortened, and along with the cough, maybe just a dry cough, especially in the night. And usually the symptoms are worse at the night and at the early morning. And there are other called exercise-induced asthma. In that patient, the patient will be having like this type of symptoms immediately after doing the exercise. And if the patient is also some like allergen exposure, like the pollens, dust, and all these things, also they get immediately this type of symptoms. Then you have to dig for the history of all these things. And sometimes there is called aspirin-induced asthma. This also there is a role. That's what, like especially a patient with asthma, asthma, you have to be very careful not to give the aspirins. And they have to dig the history for the atopic disorders in the family. Family history of asthma, somebody is having this type of atopic disorders or asthma also you have to ask. And on examination, there should be widespread bronchitis should be there. And if you go for the pulmonary function test, there should be a low FEV1 and low RPF. I just explained in the next slides what is that.
No, ibuprofen is also supposed to.
Sorry.
Ibuprofen is.
Yeah, ibuprofen also it can cause. NSAIDs, most of the NSAIDs can cause. Okay, and there may be some peripheral blood eosinophilia. If that peripheral blood eosinophilia is not very diagnostic, it can just give a clue like there may be a possibility. These are the high probabilities. Coming to the low probability of asthma, there should be a chronic productive cough in the absence of the wheeze. I told in my previous slides also, usually asthma is an airway disease. The expectation what they will get is very minimal compared to the parenchymal disorders. Compared to the, for example, any bronchiectasis. In the bronchiectasis, you will get a copious amount of expectation. Here, if the patient is having the chronic productive cough in the absence of the wheeze, definitely you have to think rather than asthma, something else rather than the asthma. On examination also, there may not be any wheeze and bronchi should be there. And usually the symptoms are always associated with the cold, and patient is absolutely okay other than the times. And if the patient is having any significant smoking history, that is more than 25 years and all the things with some sort of symptoms and all the things, your mind should go in terms of either maybe COPD or you have to think of any malignancies and all these things. And at the same time, you have to rule out the cardiac diseases. And an examination, there may be a normal PF and thus spirometry when the patient is symptomatic. This is the flow chart. Same like that kids. Here only thing is we are adding the PF or the spirometry. So any patients who has came with a suspected of asthma, after the clinical assessment, we have to go ahead with the spirometry. Spirometry is a very good test, very good tool to see for the obstruction, airway obstruction. If the spirometry is not available, the PF, peak expiratory flow meter. This is the PF also, you can go ahead. If you are strongly suspicion of this one asthma, and also spirometry also gives the clues like there is a looks like asthma, then definitely you have to go ahead with the trial of treatment. If there is a good response, you have to continue the treatment. If there is not response, again you have to check for the complaint and inhaler technique. Consider like further investigate if it is not happened. Low probability, you have to think of further something else rather than asthma. If there is not response, you have to further dig for some more investigation. Here is the intermediate probability. That intermediate probability means the patient's what the test history is not very particular related to the asthma. That time you have to go ahead with the spirometry. In the spirometry, if the FE1 by FEC level, if it is less than 0.7%, then you have to think of it as obstructive airway disease, you have to go ahead with the treatment. If it is more than 0.7, it is rather than asthma something else, you have to think of other condition rather than the asthma, you have to investigate further. Yeah, what are the important tools usually we used to do for the asthma treatment? This is the PF1. So PF or peak expiratory flow measurement. So this is, as you all know, like in a patient who came with the temperature, you used to first and foremost thing is you have to take the thermometer and you have to check the temperature. Like that, this is a very important tool for to diagnose the asthma. And very simple and very handy also and very cheap also. The cost is hardly 200 to 300 bucks. This is peak expiratory flow meter. This will you'll ask the patient to put it in the mouth, ask them to blow only once. Then you have to see that reading. That will tells like how much is the flow. Usually, normally, for the males, they are considered more than 600 liter per minute is considered to be normal. For the females, it is more than 450 liter per minute is considered to be normal. Anything less than that, definitely you have to think of there may be some sort of airflow obstruction is happening. So, and usually the diurnal variation, as I told, like early morning, because there may be some sort of narrowing of the airways, the expiratory flow will be slightly less compared to the evening time. So, if there is normally there will be less than 20% of the diurnal variability will be there. If it is more than 20% of diurnal variability, definitely you have to think of there may be some sort of obstructive airway disease happening. That means there is a airway obstruction is happening. And this is very good tool, especially in the case of patients who came with the asthma exacerbation. And usually, if there is one more test called like reversibility. You can able to check for the reversibility whether the patient is responding to the salbutamol. You know, like usually after doing that spirometry, you'll ask them to take some nebulization. Again, you have to check that out. Like that also, if you wanted, if it doesn't have that spirometry, you can go ahead with this thing also. If it is more than 50% improvement compared to the pre-test, definitely it is considered to be a good reversible. See, this is the one patient. Came with the exacerbation. So when you did in the first time, his PF was 310. So at the same time, you have to measure his height and the weight. When you measure the height and weight, it will give the predicted value. As per his age and height, its predicted is 700 liters per minute. So that time it was 44%. So I started him on inhaled glucocorticosteroids. So after giving that steroids like ICS, at the end of the 3rd week, again you check the PFR, it was 500 by 710. Okay, like that is almost 70%. See, definitely there is a much improvement when compared to the exacerbation stage. And after the end of the 4th, at the end of the 7th week, so there is a much improvement. It is almost like 86%. Why it is important? This is the patient need not to come frequently to the hospital. We can suggest him to do in the voluntarily in the home. Every day some 2 to 3 times let him do and let him monitor, let him record. So at least after 3 or 4 weeks you can just see, like you can able to tell like the patient definitely responding to the what the treatment we have given. So this is definitely a very good response, and at the same time it's very easy procedure. That's why like any patient with the bronchial asthma, so we have to go ahead with the PFR. This is I think most of the people you might heard like what is that spirometry. Spirometry initially that nobody was aware like what is that spirometry. So nowadays like for every surgery, anything if you wanted to go ahead, so they will ask for the spirometry because the lung volumes and everything it will use. It will give a very good tools for the lungs. This is the best and the most standardized test for the airflow obstructions. What is that FE1 and FEC? FEC is the forced vital capacity. Forced vital capacity is the amount of the air that is blown after the forceful inspiration. If you have seen any patient with the spirometry, you will ask the patient to take a deep breath. Then ask them to blow as much as possible. It will be like a blasting of the air. So that is called FEC. What is FEV1? It is forced expiratory volume in 1 second. So the FEV1 by FEC ratio is why it is important. Normally what it happens, the amount of the air, whatever amount of the air we are inhaling, we exhale the 90% of the air in the first second. That means FE1 by FEC ratio should be always 90%. If we take a normal person. As the age growing. So during the adolescents or the elderly persons, the FE1 by FEC ratio will come back to the. So FE1 by FEC ratio will drop to the up to 80%. 80% is the cutoff points. Anything less than 80% is significant. That shows like the patient cannot able to blow the required amount of the air in the first seconds. That means there is a airflow obstruction is happening. So that is suggested. If the FE1 by FEC ratio is less than 80%, that signifies that there is a airflow obstruction is happening. But this was the standard like, for every person. But there was the GINA, I told you, that's Global Initiative for the Management of Asthma. They have made the cutoff point for 70%. Anything less than 70% is considered to be there is a significant airflow obstruction is happening. If the FE1 by FEC ratio, if it is more than 70%, that means that is a normal. So that's what like based on the spirometry, you can able to tell definitely there is an obstruction is happening or not happening. And there are some graphs also. I'll just show the graphs. How is the graphs looks like? You might have seen this type of the graph. This is the one is the flow and this is the volume. So this is the x-axis and y-axis is the flow volume curve. This is the volume versus time curve. Here like the important thing what you have to see is this is an inhalation curve and this is the exhalation curve. Just compare this is and that one. This is a normal spirometry. The exhalation curve is almost like it is a normal. And you just see that there is a scooping of the exhalation curve. The expiratory curve, expiratory loop is scooping. That shows like based on the that shows like there is an obstruction is happening. That means the person is not able to blow the required amount of the air in the first second. So that indicates like there is an obstruction is happening. So whereas the inspiratory link just see like it's almost normal. Then there is a reversibility. Because if you talk about the spirometry, there is a definitely confusion between whether it's because for COPD also will suggest spirometry, for asthma also will suggest the spirometry. How to differentiate between whether it's asthma or whether it's a COPD? Here is the important thing is the reversibility. As you know, like asthma is a reversible disorder, whereas a COPD is a progressive disorder. It is never reversible. For example, if the person came with a grade 2 of breathlessness, he cannot come back to the grade 1 or grade 0 breathlessness in the case of COPD. But in the case of the asthma, when he came to the emergency with a grade 4 breathlessness, you can bring him back to the grade 0 or grade 1 breathlessness. That means this is a fully reversible. For them also they have made a criteria. What is that criteria? In that criteria, if the FE1 levels first after post bronchodilator, especially what you are giving is the salbutamol. After giving that nebulization, so you have to check again after 10 minutes. In that, if there is a significant, there is a more than 200 ml improvement in the FEV1, for example, or 12%. For example, its FE1 pre-bronchodilator is 2.5 liter. If it is increased to 2.7 liters, so that means there is significant improvement is there. That means it is a reversible disorder. Reversible disease means definitely you have to think of it as an asthma. It is not a diagnostic tool. It is just suggestive, like it may be an asthma. See, this is the flow volume tube. I'll just explain. Like this is there is a actually this dot line is a predicted. The predicted should be like that. So when they are blown in the pre-bronchodilator, there is a scooping is there. So definitely there is a obstruction is there. When you see that graph B, so that is the yellow line is the predicted, and that is the blue line is the actually done. Here also there is not much reversibility. When you see the graph C, almost the blue line is touching to the yellow line. That suggests like there is a good reversibility. This B line suggests you like there is not much reversibility. Based on this criteria, you can definitely tell like maybe it is a COPD or asthma. This is also one of the graph. You can see like there is a pre-bronchodilator, so much of that is yellow curve, and after post-bronchodilator, there is a much improvement as well in the case of the bronchial asthma. The same thing cannot be happening in a case of COPD patient. And this was the, I told you, there is one more called GOLD. GOLD is like a global initiative for the management of the obstructive air diseases, especially COPD. They are classified like more than 80% is mild FEV1, and moderate 50 to 80 is moderate, and severe is 30 to 50, and very severe is less than 30. Another important thing told is like FEN. What is that FENO? It is a fractional excretion of the nitric oxide. You know that nitric oxide is very complex, is commonly present in a patient in a case where there is inflammation is happening. Because in a case of bronchial asthma, it's a chronic inflammatory disorder where there is an increasing in the level of the nitric oxide. Here also the technique is simple. Like this is the FENO machine. So you will tell the patient to just keep inside the mouth, ask them to blow. That will give the records, that will give the readings. So this is much more better than what the sputum eosinophils is doing. Here the normal range what is predicted is less than 25 parts per billion. If it is a less than 25 parts per billion of this thing, this is considered to be normal. If it is more than 45 parts per billion, this is definitely excludes. There is a asthma is not well controlled. And usually this FENO is quite costly. Like it is around approximately some 2.5 to 3 lakhs. Usually the tertiary center people they will keep all these things if you wanted for the further confirmation of the diagnosis. And usually the IFNO is suggestive of it's a steroid responsive phenotype, the severe asthma. A decline, for example, if the follow-up test if you wanted to do for the FENO, for example, before starting the initiation of the treatment, after 1 month of initiation of the treatment, if there is a 40% drop of this FENO levels, that means definitely there is a good improvement is there and there is a improved control. So low levels also will predict there is a low chances of exacerbation. There are some studies they have found like this FENO and sputum eosinophils are much better than for the this one approach compared to the symptoms as well as the pulmonary functions, especially in the patients with the who are came with the exacerbation. These are the good tools compared to the just based on the symptomatic treatment. Another important thing is the sputum eosinophils. As I told you, the sputum eosinophils usually they will be more in the case of the bronchial asthma. And if there is elevated sputum eosinophil count, there is more than 10%, the chances like high risk for the future exacerbation. Normal range is less than 2%. If there is an increase in the 2 to 3 fold of eosinophil levels, that will suggest like there is a definitely the patient will be having the chances of getting the exacerbation or the asthma. If the low sputum eosinophil counts predict the response to the inhaled corticosteroids and increase the risk of exacerbation. A change of 50% like eosinophils come in the follow-up study also considered like there is a definitely good improvement in there is a good control of the asthma. This is the another important tool like you might have heard. This is that is called body box. This is also called as body plethysmogram. As I told in the previously also, this is an obstructive like usually like for example COPD or asthma is an airway disease where there is a narrowing of the airways. When there is a narrowing of the airways, the amount of the air they cannot. For example, a person who is having asthma or COPD, if he take the inhale breath like tidal volume, I mean to say tidal volume is take around 500 ml. The amount of the air is exhaled is hardly 350 to 400 ml. That means the 100 ml of the air will be remains in the lung because there is a narrowing of the airways. You cannot able to exhale whole amount of the air. What will happen? This is gradually building up. Every breath is 50 to 100 ml is get collected. Then what will happen? There is a air trapping will be happening. That's what they are called air trapping. When there is a air trapping it happens, there is increasing in the residual volume. There is increasing in the functional residual capacity. Totally there is increasing in the total lung capacity. So when there is increasing in that lung capacity, this body plethysmography just tells like there is a increasing in the residual volume and total lung capacity. Based on these things, you can able to tell like either it may be a COPD or it may be a bronchial asthma. But it cannot able to differentiate whether it's a bronchial asthma or COPD. It will just calculate the volumes of the lungs. So based on the volumes of the lung, you can able to tell maybe it's a COPD obstructive airways disease. And I told about like what is methacholine challenge test. These are the tests are very important thing, especially this is a test you have to do for the airway hyper responsiveness. Because you might be seeing so many kids and all the same. They come with a complaints like my kid is having suddenly like wheezing and breathing difficulty, all sorts of things and phobia, like maybe some sort of tension, exam tension and all the same. When you examine, absolutely normal. And another different entity, especially the occupational asthma. So one person, some particular person, if he had been exposed to some particular environment, if they are, for example, working in some mines or somewhere, they'll suddenly start all sorts of symptoms. When you remove from that environment, they will be absolutely okay. If you wanted to check for this type of scenario, you have to go ahead with this is called the provocative challenge test. You will stimulate the airways. You will see like how the airways are reacting. So here what you have to do is methacholine. This is a muscarinic agonist. So you have to give the nebulization in a doubling concentration. So first, before that doing the test, you have to check the spirometry and you have to calculate its FEV1 in the baseline. And after doing that, and every 10 minutes, you have to give the doubling dose of the methacholine through the nebulization, and you have to check the spirometry every 10 minutes repeatedly. When the FEV1 is drops from the for 20% from the baseline, that means there is a significant drop of the FEV1. That is called PC20, provocative concentration 20%. That is 20% fall in the FEV1. So here also, if the PC level is less than 16 milligram per deciliter, it's called mild AHR. If there is a, for example, if you are giving 1 or 2 nebulizations, suddenly they are developing this type of drop of the FEV1, that means their airways are very fragile and there is a airway hyperresponsiveness is there. If it is less than 4 milligram per ml, it is consist of moderate AHR, and if there is a less than 1 milligram per deciliter for ml, it is called severe AHR. Especially it is very helpful in a case of the occupational asthma or the patients if you are really having the symptoms, or if you wanted to rule out whether they are really suffering from the asthma. Especially if you wanted some people there who don't want to work in particular environment, they will come with the symptoms, and if you wanted to go out with this test, you can tell like the patient is having the symptoms or not symptoms. And this is very risky procedure also, and you can't do this in like a OPD setup or in the clinic. There should be tertiary level test. Suddenly they may go for respiratory apnea and all these things, so they may need ICU care, intubation and all sorts of things. Yeah, there is a normal airway response. You can see like it's a mild and moderate and the severe airway hyperresponsiveness. There is an indirect stimuli like that only methacholine. So instead of that methacholine, you can give the hypertonic saline or mannitol, and you have to do that exercise, and also you have to see for the spirometry. There is a skin prick test, as I told in the previously. They are doing the skin prick test for the minimal normal antigens, especially the dust mites, cockroaches, and the parthenium, and especially this dander of the dogs, cats also they will do. If it comes positive, then you can tell like the baby or the person is atopic. Based on atopy, you cannot able to diagnose this as a bronchial asthma. There is a chance like he may land up into the bronchial asthma, and there is a rise specific for the IG to the cats and the dogs. This is the X-ray picture, because X-ray is not very good tool to tell that whether the patient is having really bronchial asthma, but to some extent definitely it will tell, because most of the clinics, most of the person, if it comes with any sorts of respiratory concerns, immediately they are go ahead with the chest X-ray. See, this is the chest X-ray, it is absolutely normal. You can see the difference between that X-ray and this X-ray. There is the lungs looks like very big compared to this X-ray. See that heart shape. This heart shape is very narrow. That is called the tubular heart. See the diaphragm is completely pushed down. So that is called, there is a hyperinflated lung. That is called signs of hyperinflation. So usually it is common in a patient with the COPD as well as the bronchial asthma patient. So to conclude my investigations of choice, usually the preferable is the methacholine challenges. The sensitivity is very high. So normal range is more than 8, if less than 8 is considered to be significant, and indirect challenges are like that's not very significant because the sensitivity is medium. FEN also is very significant, sensitivity is very high, and sputum eosinophil counts also it is. If it is normally less than 2, if it is more than 2 is considered significant. As well as PF also, but if it is more than 20%, that's also very significant. Few slides regarding the management. Too much, huh? Yeah. I don't know, but if you want me to cover, like
Yeah, you can
This
finish.
is more important. Management is
important.
important.
Okay, I'll just finish in 10 minutes. Okay. Yeah, management of asthma is mainly pharmacological and non-pharmacological management. So pharmacological aspect, they are mainly divided into the reliever medications and the control medications. What are the reliever medications? Reliever medications are the drugs which are used in the emergency purpose, and they will give the immediate and instant relief, but they cannot be used as a preventer or control medication. Mainly the beta-2 agonist, short-acting, that is salbutamol and albuterol and all these things. Anticholinergic, that is ipratropium, bromide and all these things. Thiopidine. Coming to the controller medications, usually the inhaled glucocorticosteroids and leukotriene modifiers. And this is the long-acting beta-2, that is LABA plus ICS. Long-acting beta-2 agonist along with the inhaled glucocorticosteroid and systemic glucocorticosteroids and anti-IgE also. This is the levels of asthma control. So how to step up and how to step down the treatment. This is very important. How they'll divide the asthma into the controlled, partially controlled and uncontrolled, mainly based on the patient symptoms. One, there is a daytime symptoms and there is a limitation of the activities. Usually patient with the controlled asthma, the daytime symptoms will be less than twice per week. Where there may not be any limitation of the activities, there may not be any nocturnal symptoms, and the need of the reliever medication is hardly twice per week, whereas the lung function is absolutely normal. If it is partially controlled, then maybe all the symptoms will be there. If it is uncontrolled, more than 3 symptoms of the partially controlled is considered to be uncontrolled. This is very important for the management of the treatment of asthma. This is the guidelines as made by the GINA. There are 5 steps for the management of the asthma. I'll tell each steps. Okay. Yeah. This is the step 1. Step 1 is the patients who are came with once in a while there comes with the asthma symptoms, like especially wheezing, and there may be family history will be there and all sorts of symptoms. That type of patients, first and foremost things you have to educate about asthma and what are the precautionary steps to be taken to also you have to explain. And you have to start with, you have to give only the short-acting beta-2 agonist, that is Astalin inhaler or levosalbutamol inhaler. He needs once in a while, it may not be needed. First you have to give that medications. This is the step 1. In case you have to escalate because the patient may not be happy with that only the reliever medication, then you have to step up the treatment. Here is the introduction of the preventer medication, especially low dose of inhaled corticosteroids. Here is the low dose of, instead of like along with your reliever should be there, along with you have to start with the controller medication, that is low dose of inhaled corticosteroids. So either budesonide or fluticasone, whatever maybe, there are many these things are there. So you have to give low dose. Low dose means like less than 400 is considered to be low dose for the adults, and less than 800 is considered to be medium dose. Less than 1000 is more than 1000 is considered to be high dose. Especially the pediatrics, half of the dose. This is in case, for example, the kids who are less than 5 years, and some people are very reluctant to take the steroids because everybody knows that steroids have so many complications and all this thing, and they might have read in the internet, they'll tell like, so this is so many complications, I don't want that steroids and all this. That time definitely you can go ahead with the leukotriene modifiers, that is Montelukast, Jefferlukast and Gelatin tablets. This is the step 2. If the patient is comfortable with that step 2, just you can go ahead with that thing. If still the patients and the baby is not controlled with that type of symptoms, then you have to step up again the treatment. Here, along with the low dose of ICS, you have to add the LABA, long-acting beta-2 agonist, that is salmeterol or formoterol, along with your inhaled corticosteroids. Closer.
Choose down.
So here, like along with the low dose of the ICS and this is, or else the other option is you can increase the instead of low dose to the medium dose of the ICS instead of adding the beta-2 agonist. That is second option. Our third option is ICS with the leukotriene modifiers instead of that beta LABA. Our last option is low dose of ICS with the sustained release of theophylline. This is a step 3. Even if the step 3, if the patient is comfortable for at least 1 or 2 months, you can just go ahead and continue the same treatment. Step 4 is the, after adding all this medication also, like if the patient is not comfortable, here along with that LABA plus ICS, you have to add one leukotriene inhibitor, like leukotriene modifiers, like montelukast or gefapixant. This is the step 4, along with the reliever medications. Then the step 5 is the very important thing. When the patient is not able to control this stage, I think you have to refer to some specialization people who can able to handle this time. Here, like you have to start him on the oral glucocorticoids. Oral glucocorticoids, you have to start as minimal dose as possible. Initially, for the exacerbation stage, you have to give a higher dose. For example, 1 milligram per kg body weight you can give for at least some 7 days, and then gradually you have to taper. And if you want, like you can keep around 5 to 10 milligram per kg body weight, 5 to 10 milligram per day. I got this one, and another important thing is anti-IC. Anti-IC, I think you might have heard, like that is called omalizumab. This is a recent molecule. This is especially used for the kids who are having like positive skin prick test for any pollens and all these things. You can use that anti-IC treatment. It's really working nice. But only thing is it's quite costly, and you have to take for at least some 2 years of course. Every 4 weeks, one injections you have to take. That is a subcutaneous injection. Yeah, this is the step of treatment. So once the patient is come back to the normal, so if you feel like that first step I told you, there is a control, then you have to step down the treatment. How to step down? Because yeah, whatever may be the things, ICS, whatever may be you want to tell, definitely there is a side effect from the ICS. Because there is a side effect is there. You have to, once the patient has come back to the baseline or the control is there, then you have to step down. How to step down? You have to monitor for at least 3 months. If the patient is on high dose of inhaled corticosteroids, you have to cut short to the 50% dose of the steroids after 3 months. That is especially ICS. When the patient is controlled with the low dose of inhaled corticosteroids, only that low dose of, for example, budesonide, 200 mg, 200 micrograms BD if you are giving. So after 3 months, you are just monitoring. He does not have any symptoms like daytime symptoms, and all the symptoms very less. Then instead of 2 times, you make it to 1 time a day. Another important thing, if the patient is on both LABA as well as ICS, here like you can reduce the inhaled corticosteroids by 50% by continuing the LABA. For example, 400 micrograms of formoterol plus, this budesonide plus and formoterol if you are giving. So you have to cut short it to the 400 to the 200, along with the LABA should be continued. If your control is maintained, you can reduce the low dose of glucocorticoids and stop the beta-2 agonist. And just you can continue the ICS and stop the LABA. But only one important thing here you have to observe is the ICS are the drug for the asthma. Don't stop the ICS and continue the LABA. Many patients you might have seen, like they are telling, like if you ask, like, sir, I'm just using the Asthalin inhaler, sir, since 2 years or 3 years. That is not the treatment for Asthalin. There was a study has happened in the British. So they found like the patient who was on salmeterol with the placebo, giving the salmeterol is most dangerous thing compared to the placebo. Because the pathology or is the inflammatory process. If you are just giving the bronchodilator, it may not help. Bronchodilator, it is just that time the patient, if he is having any breathing difficulty, it can give that instant relief. But for the continuous or the prevention or the control medication, always it is an ICS, inhaled glucocorticosteroids. The non-pharmacology I am not going to in detail because there is a primary prophylaxis. That means like the patient is already having history of atopic, and so in that patients we have to try to avoid the allergens. And they are also found like there is a dust mites and all these things also can cause the worsening of the symptoms. So we have to avoid that one. And food allergen, they found like there are some eggs can cause this type of symptoms. So if the baby is having that type of allergy to the eggs, better to avoid. And especially tobacco smoke, like it's the most dangerous. And this is one of the commonest culprit to worsen and deteriorate the asthma. Any person over the pregnant ladies, if you want, if they are smokes, definitely within a year of the baby they can get the symptoms of asthma. So especially pregnant ladies should be avoid the smoking, and in the family also better to avoid the smoking. Breastfeeding also they found like because some people they may scare like I'm having that asthma symptom, if I fed my baby, they may be baby also may get the things. Definitely there may be that, but at the same time the positive factor compared to the breastfeeding is much more than this getting the asthma. And animal allergens I told you like cat and dogs and all these things. Pets, any patients who are having the asthma symptoms, better to advise them avoid the pets. Pets are also one of the most commonest culprits to exacerbate the symptoms, and especially obesity. You may see like especially nowadays there is so much of obesity. There are some criteria like if the patient's body weight, that is BMI, is more than 30 kg per meter square, is more prone to develop the asthma with a family history of atopy. And at the same time, it's very difficult to control a patient who are having the obese patients. And especially this our good old like our Indian these things, yoga, meditation, really helpful for the patients who are having asthma. Better to suggest them advice for the breathing exercise, walking and yoga. Secondary prophylaxis, like already they are on the developed asthma, they are a known asthmatic patient. How to prevent the further exacerbation? Especially this the dust mites. I told you, dust mites are the most commonest culprits to develop the exacerbation. Dust mites are present everywhere. You cannot able to avoid. Definitely to some extent you can able to prevent. The most commonest place the dust mites are present in the blankets, pillow covers, bed sheets, curtains, floor mats. Ask any patients who are having the asthmatic patient, ask them to clean especially the bedrooms, this thing, once in 10 days or once in 15 days, so that definitely we can able to prevent this the dust mites. And also avoid that this one like toys and all this thing. That's also can trigger the asthma. Nutritional supplementation, there are some studies they found like there is a omega-3 polyunsaturated fatty acid, that is fish liver also. The Western people they are taking less. That's why they are getting the chances of high possibility. So if at all if you want to suggest, you can suggest that fish liver oil, but there are not many studies to suggest for this one. And another important thing, they have found like there is a selenium and vitamin E. The people who are taking less during the pregnancy, or there is a chances to develop the asthma. This is the immunotherapy. What I told like especially the patients who are having that positive skin prick test, especially the colons, we give the immunotherapy. Definitely it works very good. And they have done some study like if you are giving that immunotherapy for 3 years and they stopped for 2 years, the patient, the baby is completely absence of symptoms. But so it's very costly procedure to done in our Indian setup immunotherapy. It started in established in India. Very few centers they are doing the immunotherapy, and all the vaccinations should be given. So this is one of the recent modality for the bronchial thermoplasty who are not controlled with the asthma. Yeah. Before concluding my diagnosis, just I wanted to tell like this is a beautiful hypothesis. It was done by the British people. Many people are accepting and some people are not accepting. Being the parents, what we are doing, our kids is really justifiable or not justifiable. You can see like there is a graph. If a kid is being exposed to the daycares and if you have been exposed to the viral infection, exposed to the farm environment, that is especially rural setups, if the baby is having instances of tuberculosis, the baby will develop the T helper 1 type of immune response. This is really good for that asthma. The baby may not develop the asthma. On the other side, if the babies, if you are in a very clean environment, very Western lifestyles, you will avoid joining, you will avoid going outside and all the things. If you are keeping a
So thank you, Dr. Shivaraj. I'm going to continue in the same theme. So, the reason the topic that I had food allergy really is 2 reasons I thought. One is for us physicians, because there is a lot of skepticism saying that food allergy is it's more of a developed nation disease and burden, and we don't have it enough. And so is this a burning topic to talk about? And the other reason is for the patients that especially in our Indian setting, that do they really have food allergies or what is it? So I just thought we'll start off a little light. Now my aim of this talk is one, of course, you get a little bit more knowledge about food allergy, and hopefully by the end that I'm talking, you're not squirming in your seat and checking your texts and mailing people. So I've asked my 12-year-old to help me out a little bit so we can perk up the talk a little bit. So anyway, so this is I don't think that this is too unrealistic as we go from now, that we're going to be trying to figure out where your kid can be in a gluten-free or lactose-free or peanut allergic class.
Mostly, maybe it's already there in Western world, not here.
So, the incidence of food allergy and the severity of food allergy is on the rise worldwide. So, it's not just the developed countries, but also the developing countries. As the next one says, in the last 10 years, not a single country, either developed or developing, has had a fall in the incidence of food allergies per se, food as well as air allergy. So the incidence worldwide is about 5 to 8% in children and 1 to 2% in adults. And this is worldwide, so this is not in the US. And you'll see, of course, it's higher in the US, it's 8 to 9%. About 220 to 250 million people are suffering from food allergies. I've got this figure of 3% in India. That is a pretty high number. And even if it's not close to 3%, it's still a pretty high number considering we are 1 billion people. So the very interesting fact is there's been a 50% rise in the food allergy in the US between 1997 and 2011. And a lot of these figures are going to be US because a lot of the research and the paper and the stuff that I can get is from the US, and we'll come to that because we really don't have any a whole lot of research going on here. So just basic types of food allergy. Food allergy, I'd like to make a little bit of change here. They are mainly IgE mediated. There are few of them that are not IgE mediated. They're the delayed hypersensitivities. The food allergies usually have a skin, GI, respiratory reactions. And the reason I point this out is they are quite specific reactions. So you will see of note a lot of people coming off that they're allergic to something because they eat in. That again should go with what the symptoms could be because of allergy, because majority of the studies do not show symptoms, be totally out of what have been studied. Then there is an entity called food-dependent exercise-induced anaphylaxis, in which it is a scary but interesting phenomenon. Is the person has eats certain kind of food that they're allergic to, and then there's exercise that kind of induces the histamine, and I guess it's delayed, so it's non-IgE mediated, but they get anaphylaxis. And the very new entity that's come in the realm right now is the FPIES, or the food protein induced enterocolitis syndrome, which is when kids are allergic, they kind of adults too get into a severe enterocolitis where they can have severe bleeding and can get really sick. So starting off with pathogenesis, the first thing is a disclaimer here that the number of people with food allergies is growing, but there is no clear answer why. So we're going to try to go through all the things, but I wish food allergies and asthma and a lot of these things had one thing that we could find out, because majority of the things, including diabetes, all the autoimmune, most of them are multifactorial. So there's no single reason as to why a person is having. There are several hypotheses. Now this is this food allergy research and education organization is a pretty well-known organization, and even they put that in their in the introduction, because it is the pathogenesis is still an enigma for all of us. So there are various hypotheses. One is the hygiene hypothesis, and now the hygiene hypothesis I actually always would not agree, because the US has been clean for a good 50-60 years, and the rise of the allergy has only been in the last 20 years. So it's not just the hygiene. The hygiene of the way, now that I understand after reading all this, is what happens is with a lack of early exposure to infection, so the normal gut microflora is not developed. It's kind of very naive, the gut microflora. And we'll see later on how does the gut microflora help in kind of preventing food allergy. So the gut microflora, what it does, it induces tolerance by, it increases the mucus production. The gut microflora causes slight inflammation, causes increased IgA production, and causes increased interleukin-10 production, which is interleukin-10, we'll come to that, is one of the protective or the tolerance oriented interleukin that is generated in the body. And of course vitamin D. We talk about vitamin D in every talk. Vitamin D deficiency has seen this, and there's some good research done by University of Melbourne, and on quite if I remember correctly, about a good 10-15,000 people that they did the research on, and they did correlate significantly with the low vitamin D level for the kids to have a higher incidence of food allergy. Dietary fat, again, the less omega-3 fats that we consume, that's more in your olive oil, and the more N6. Now this is all technical, but one of the reason is the dietary fat that I think, because this can alter the way your IgE production is. Very important is the dual allergen exposure, because and what is thought of, because a lot of kids, including my son, when they're allergic to something, they've really not been exposed to that. They have not been exposed to the food, and the first time they were exposed to the food, they had an allergic reaction. And the reason thought for that is the primary exposure is through the skin. So, and not of that food, but of that homologous protein that can be present in your ointments, in your lotions. And then the secondary exposure is through the gut, and that will cause the allergic reaction. More and more that I read of it, and I've been doing it for the last several days, I am moving away from a lot of artificial emollients for the skin, because there is a lot of research going on as to how the things present in there can get the kids, especially with an atopy, because the skin barrier is not there, to get exposed to those antigens, and then later on get the food allergy because of that. Very important is food processing. And luckily in a lot of our Indian diets, we have boiled peanuts, and boiled peanuts or groundnuts do not, there's a denaturation of the protein that does cause the ERA H and the ERA C that causes the food allergy, versus roasted, which is very common in the US and in Australia and in UK, where the roasted peanuts are used for, and roasted, when I say roasted, is more fried, are used for peanut butter and for other dishes. So that's very important. And then we come to C-section. Various research is going on. What they say is, with the C-section, when the kid is not born normally, not born vaginally, the gut microbiota is not stimulated enough, and that gut is not as healthy, and that can lead to, and the trend that we see now is a lot more C-sections, so hopefully people will pay a little bit more attention. Of course, breastfeeding, which is always universally good, and what it does, it does colonize the gut with the probiotic bacteria. It provides the IgA, and it decreases the mucosal permeability, because if you have more mucosal permeability, there will be more intact protein that will go inside, and then there's the gut-associated lymphoid tissue, which is going to then attack that, and you have more chances of food allergy. Then, in more and more research, a couple of outliers, I'm just for interest, just putting it down there. One was a big notice, and this study was done by National Institute of Health of US and of Norway, and this is a chemical called triclosan, and triclosan is there's a typo there. It's found in toothpaste. It's antibacterial, found in toothpaste and deodorants, a lot of them. And I checked mine just to make sure it didn't have any. But what they've shown is when there is a high level of triclosan in the blood, they have associated with high food allergy, and especially the toothpaste, because the mucosal absorption is pretty high when it is in the toothpaste. The second, dichlorophenol, which is a chemical found in insecticides and in weed controllers, and it makes its way to the tap water. So this was a study done by American College of Asthma, Allergy and Immunology, but basically trying to find why these things are happening and kind of getting bits and pieces. Hopefully over time these will come together, we'll get a better picture. Now Dr. Shivaraj did illustrate this briefly. I'm going to say it very briefly too. We talked maybe about 10-15 seconds. It took me about an hour to understand this, and it's been taken about 2 decades for the scientists to give us some of this information. So basically, there's the cellular immunity related to the allergy, which is the T cells. There's the humoral with the B cells, and then there's the cytokines that play a role. In the cellular immunity, the T helper cells, they are the TH1, TH2. I did not write the TH17. That's a new T helper subset that they have found, and then there are the regulatory cells, the Treg, the TR1, and the TH3. And then they both could have either CD4 or CD25. But basically, the way, what generally they're saying, there's a TH1 which is more responsible for intracellular organisms. And the kind of interleukins that it does prefer does cause more of tolerance versus TH2, which is more responsible for parasitic involvement, for parasitic immunity against parasites, and does kind of interleukins, the IL-13, the IL-5, IL-4, that it does help secrete, will cause more of the allergy, because the IL-5, it actually increases the eosinophils to kind of get the eosinophil around there. The B cells, the way the IgA helps is it binds the proteins in the gut lumen, so these proteins are then not absorbed, and then the body does not respond to it. While the IgE, that's the main perpetrator, that's how things kind of cascades happen. The cytokines, just a brief note here. So as I said, the IL-4, the interleukin 4, 13, and 5, they are the allergenic ones. And the interleukin 10 and the tumor growth factor beta, they are the ones that do cause tolerance. Sounds like the TGF beta causes the T and the B cell to not work as hard whenever there's an exposure. That's how you develop tolerance. So we come to the diagnostic test. Again, the skin test is still considered to be the gold standard. The sensitivity and the specificity of the skin test is 85%. The next is the RAS test, which is commonly all of us know about it. And interestingly, the RAS test, the radioallergist sorbent test, was introduced back in the 1950s, 60s, and actually the radio part of it was already gone for the longest time. We've actually been using the fluorescent immunoassays, which have been said as RAS, but they're not actually RAS. Up till not too long ago, up till I would say 3 or 4 years ago, the standard immunoassays were used, and the specificity, you can see it's all over the board. It's 30 to 95%, and the sensitivity is 60 to 95%. But now the CAP immunoassay, the CAP-FIA, is definitely much better, and a lot of studies are comparing it to the skin test and kind of neck to neck there. 95% of positive predictive value. So interpretation of the test. So I tend to do the immunoassays more often, because the good thing about immunoassays, my kids don't have to be off antihistamines and don't have to be off corticosteroids for some time for them to get the skin testing done, which is very important for skin testing. So if there is a negative immunoassay with a positive history, then we go for the skin test. Okay. If there is a weakly positive immunoassay, then the skin test to kind of confirm it, but you can be brave enough to do an oral challenge and to see, because weakly positive immunoassays might not really be positive. Very important to always get a total IgE count whenever you get a specific IgE, because if there is a very high IgE, you can get everything red, everything positive. So you can get quite a lot of false positive. Here I've briefly written what's the allergenic level. We'll come to it when I talk about the test. So every allergen has a specific level, which is the allergenic level is where you see the symptoms, where it could be significant, where it has to be avoided. Briefly, main 8 allergenic foods which comprise 90% of the food allergy is peanuts or granules, tree nuts, which is almond, pistachio, cashew, walnut, pecans, wheat, milk, soy, eggs, fish, and shellfish. Now in India, there was also we found some allergenic responses to brinjal, cucumber, ladyfinger, papaya, and again just a single study, so cannot be really quoted anywhere except in this talk.
The gluten is in the wheat, right?
Huh?
Gluten?
See, gluten is sensitivity, is very different than food allergy. That's an IgG mediated reaction. This is an IgE mediated reaction. So we start off just to change gears a little bit with a case presentation. So I had a boy K come in, 4.5-year-old, very exuberant boy. Came in and parents were very concerned that the kid had several food allergies. So on talking on history, what all he's allergic to. So the child was allergic to eggs, he would get hives with eggs. He was allergic to milk, he would get rash and diarrhea. He was allergic to wheat, he would get a rash. He was allergic to cocoa, mango, peanuts, pet dander, I mean you name it, he was allergic to everything. The mom had been to several places, including some neurologist specialists not in this city, and was told that the child had some allergy to legumes and the child is going to develop epilepsy if he keeps on being on that. So of course, so now let's see what the diet. The patient is on rice, ragi, few fruits, vegetable diet. When I heard that, I was totally shocked, because when kids are growing, they need as much inclusive diet as possible rather than exclusive diet which there's no protein in here. And I'm still trying to put my finger as to what that disease is in which the child will develop epilepsy with the protein. But anyway, so did the whole physical exam as usual. Well, I shouldn't say as usual. This was good. Kids who who do tend to have food allergy are atopic kids, so they can have traces of eczema, they can have wheezing or asthma. A previous blood test was done. This was about a year ago, I think so, and this was the standard RAST test. The patient was allergic to mite mix, and the class will come to it in a minute, and epithelia. So after careful examine and asking, I decided to do the CAP FIEA test for the kid. I hope you can see. So in the CAP FIEA test, the thing that the kid was allergic to here is, if I don't know if you can read, is the mite mix is what he was allergic to. These are the different classes, and as I had mentioned earlier, that every allergen has a certain level where the significance of allergy really is, and so for most of the allergens is class level 3 or more. And I've seen that with my son, I've seen that with a lot of my patients with allergy, is once they hit class 3, they'll definitely be symptomatic with that food. If they're less than class 3, they can majority of the times take that food and not have any problems. So the only thing the kid came out positive to, really positive, was the dust mite. Was not allergic to eggs, not allergic to milk, not allergic to peanuts, not allergic to, let's see if I can read this better. I had done, the mom was concerned about mango. I didn't have a mango in there, so we just did fruit, came out to be negative. Not allergic to wheat, not allergic to cocoa, not allergic to pet dander, not allergic to almonds, not allergic to coconut. And you do see a few lines here. Now if you see it carefully, they are like level 1 or 2. And I wouldn't really consider that to be positive. Said that, very important to do an IgE. And the IgE in this child was very normal. So with this, the mom was still not satisfied that the child is not allergic. So we decided to do a skin test also to make sure. So the skin test, the basic, the histamine standard, and the negative saline standard. And then you see the only thing the child is allergic to dust mite, which we already saw in the CAP FIEA, and the cat epithelium, which we did not see, but this is again 1+. Dals, he's fine. Mold, 1. If there is dust mite, most of the time there is mold. And mango, we did get 1+. So, what the reason I put in here is, a lot of times you will see kids come in is allergic to this, allergic to that. but we really need to find out what the kid is allergic to. So now that the kid is, I've introduced back to him all his legumes. He's all back on legumes. He's back on wheat. We've introduced the milk back. The egg we'll slowly kind of venture into. And I've told him to stay away from mango right now. We are getting him on the hypoallergenic, the dust mite hypoallergenic prevention sheet covers and pillow covers, and monitoring him since then. Now, just briefly talking about, we're still working on what's the pathogenesis. There are some therapies out there. I'll briefly go through them. The immunotherapy, as was mentioned, now the immunotherapy is not very expensive. The immunotherapy is not expensive when it's an oral immunotherapy, though I've not really found anyone doing oral immunotherapy here. But oral immunotherapy has been done for peanuts, for eggs, for milk, and successfully the patients have been tolerant for about 24 months after the period that they have been put on oral immunotherapy. Like for oral immunotherapy, for a patient who's allergic to peanuts, I would say 1/25th, 1/50th part of a peanut is death for that patient. And these patients have been brought up to where they can have 8 or 9 peanuts without having any problems. So if that, you can make a life-changing change when you do these kind of therapies. So there's oral immunotherapy. The other one that is subcutaneous immunotherapy. Now subcutaneous immunotherapy has been going on for a very long time for aeroallergens and has worked wonders. Now it's been introduced for food allergens, and subcutaneous does take a little bit longer than the oral, but causes less chances of anaphylaxis versus oral, because oral we are a little bit more aggressive and we go a little bit faster. Other one that's catching up is the SLIC, the sublingual immunotherapy, in which the allergens are introduced under the tongue, and then the lymphoid tissue, that is the oral lymphoid tissue, does absorb the allergen, and that's how the tolerance is developed. And for that also, that does cause much less anaphylactic or reactions or unmanageable reactions as compared to oral immunotherapy, but does take much longer time. A couple of new things which are still in the pipeline, I wouldn't say the pipeline, more research, is, well, anti-IG is not a research. Anti-omalizumab has been used. It has not been successfully used for food allergy. There were several trials in which they tried to use the omalizumab along with the oral immunotherapy and tried to see if that would work. Just a single study was going on, and that was also stopped because of some side effects. So there's really not been any breakthrough in the anti-IgE as yet. Short peptide chain, very interesting concept, is the short peptide chain of the antigen, which has the antigenic part in it, is introduced to the patient. And this short peptide chain is short enough that when the IgE connects, there is no cross-linking of the two IgE to get the histamine cycle on the roll. So they block the IgE but do not cause, and the IgE does attach to it but does not cause the consequences of the food of the allergy. That's still in the work. And last but not the least is the genetically engineered food. They've come up with hypoallergenic peanuts, hypoallergenic eggs, in which they've changed the protein slightly, and where the antigenic part is kind of hidden, and that way it doesn't bring out the IgE reaction. So these are the last three, I say, are more in hopefully in the next several years they will be out. The first three are already out. So so I hope I did not bore you too much. And here is our baby bear and papa bear and mama bear, and our Goldilocks is lying all down, and baby bear says, well, maybe she's allergic to gluten. Thank you.
So any questions?
These tests you're talking about, what, will you do all the tests in Bangalore, all the testing?
What testing?
Like
the CAP, yeah, the CAP FIEA, yes, you can get it done in Bangalore.
Through whom?
There's this, FIEA is the original company, and FIEA is doing here too.
So 5-year top is doing it, and then we do it here in RxDx. So
You
if
just
you
draw
want
the blood. Is it?
We draw the blood here and then they
samples
collect it.
Sent out.
You're not giving the other blood, sending the whole blood to somewhere for all the tests.
Yes.
Some other place.
No,
You are-
it
you
goes
are.
out.
It
Oh,
goes
that's
out.
somewhere, where is it? Is it near the Victoria Hospital?
I don't know
Richmond,
exactly.
somewhere close there.
Yeah, but it is in
Another.
downtown.
This is
Yeah.
the same person that Dr. Kusharappa sends you. Is it the same?
I don't know.
I don't know.
It's Fadia. Thermo.
And they're reliable.
Yeah.
It's all. It's all
Well,
accepted.
Fadia was the original company that introduced this CAP FIA in the US. This was about 3.5 years ago. And that it got an FDA approval there. That's when it started getting used in practice. And it's been here, that I know of, is about a year, Gurmeet?
Little over
Yeah?
a year. Yeah.
Yeah, about a year.
So how many allergens are you testing again?
They have a huge range. They have a huge range of allergens. And then they have these, the Faria top is what they've been advertising a lot. And in which they have like 200 some allergens that they check in there. But Faria top is not very specific. So I usually don't do Faria top, and I've talked to several allergists and they don't recommend that too. But then you can, then they have their own panels. They have the South India pollen panel, they have the food panels, they have the vegetarian panel, they have the non-vegetarian. You know, one thing I forgot to mention here, I think so I missed out in the slide, is very important is the food allergy that a lot of people have with fruits and vegetables. And that is not, that's a food pollen allergy syndrome. What it is basically those fruits and those vegetables, they have the pollen from birch and other trees which have homologous proteins to the vegetables that they'll be eating. So it's not the vegetable that they're allergic to as such, it's more of the food allergy. And I think so for that, the only way to get rid of that is kind of having tolerance over, because they usually will not cause anaphylaxis.
But if a mother asks you, why do you want to do this? Why don't you do a skin allergy testing? Then what would you give?
Yeah. So what I say is, I personally don't do a skin allergy test. So we can do a skin allergy test too. Not either skin allergy test is also not a pleasant test. When it's done, it's a skin prick. There are several ways. There's a skin prick intradermal or a patch test. Patch test pretty much no one does here. And patch test, patch test can cause an eczema and lot of problems. So usually you go by just a skin prick. And it's done over the kid. First of all, the kid has to be off of antihistamines for a good week, off of any corticosteroids for some time. Only then you can do it. And it's not, I mean, the kid, once it gets, they'll get wheal, they'll get itching, they won't be happy. Of course, here is a blood draw, which is not a happy situation either. But I can test for a lot more things with a CAP FIA in the amount of blood that I get versus the skin testing, because you only have certain amount. You can, on younger kids, you do it on the back. On older kids, you can do it on the forearm. But you could do both. So that's how I go, is I go with what I can do. And then if there is any questions, then we go for the gold test, which is skin testing. Because a lot of times the skin testing, you just cannot get the kids off the medicine for that long. Or they cannot come at that time where the kid has been off for so many days. Something or the other comes up and then they're again stuck, and then you have to get the kid off again and come. So that way this works out a little bit better.
I think it's nasty for children. That's why skin test probably is not preferred. B, in immunocap, you can get polysensitization. You can see a lot of allergies to a lot of things. So they say, most allergists say that they prefer the skin test, but in pediatric age group, I think the problem is just the whole deal of doing it, and how many do you test? But it is supposedly more specific than the immunocap test. But immunocap is very close.
Yeah, but again, you have to see where it is. That's why I told you the different classes. Because if it's less than 3, and if there's a low IgE level, which I did for this kid, we go for an oral challenge. And if there's less than 3, the chances that the kid will have an anaphylaxis is pretty much 0. Of course, if the kid has a 4 and a 5, there's no way you will try up an oral challenge.
And like you said, with the high IgEs, everything can come as possible.
Yes, and we see it very often. And then the kid is off this, and then
Mom,
you ask,
there
the
is
kid
lost.
used
What
to be
can
on
we
this and
do?
used to be fine, yes, but now that the test shows me the kid is off everything. So the other thing, very vehemently, the American Association of Asthma, Allergy and Immunology has said is the first thing to do is a thorough history, and the first thing to find out is it's very important. Historical food allergy is much more important than what you get from the test, because the test can be positive, but that doesn't mean that the child has it.
Yeah, that's it. So better to keep a food journal.
And to add to your list of things, I've seen adult tomato allergy.
Yes, so that's the food pollen allergy syndrome that I'm talking about. So it's not the tomato proteins that they're allergic to, but they're allergic to the food pollen, and usually it's birch food pollen that has homologous proteins with the tomato, and that's what they're allergic to.
And also in one UK child, the child was allergic to peanuts. Her classmate had peanuts, and she just blew into the mouth, and she really got an anaphylactic reaction.
That's kind of.
My son has similar peanut allergy. So I did. And it's sad when kids have peanut allergy, because now I'm a mom of one and I know how socially decapacitating it is, because I cannot let my son go to their friend's place and play. I have to be there, because peanut allergy is, again, it's a myth in most of the places. Oh, yeah, he's fine. But when there's peanut allergy, if anyone else has peanut and touches my son is going to have a problem. So, thank you for taking your time.
So we'll just end up the session. Thanks Dr. Sonal and Dr. Shivaraj for a wonderful session. I think we can continue our discussion on allergies, an ongoing topic and a very hot topic. We surely would continue this in the clinics too. I'd request Dr. Chavi to present a bouquet and memento to Dr. Shivaraj. Thank you. And we appreciate Dr. Meera coming here and spending, encouraging us. I request her to give bouquet to Dr. Sonal.
Thanks, Siddharth.